Ready.
Okay, so it's a great pleasure for me to have one of the alumni of the University of Miami on our program, Dr. Sonal Choudhary, who is a young superstar of dermatology and dermatopathology. She is hailing originally from India, and then she did a postdoctoral fellowship at the University of Miami, and then she was recruited to University of Miami. She did her dermatology residency, and she was also a dermatopathology fellow in the dermatopathology fellowship. She did it in the Pittsburgh Medical Center. I met her here in Miami, and I have to tell that she was, in my career, one of the most enthusiastic person towards pathology, dermatopathology, and it was a lot of fun to work with her. Up until recently, I met her repeatedly on different meetings where she's an invited speaker, and it was always a fun experience to meet her and to interact with her on different interesting dermatopathological cases. So it's a great honor for us to have her on the program, and because she's also originally an international student of medicine, it's a great thing to have her on this program. So for all that, I would like to ask you, Sonal, to start your lecture. We are very much interested to learn about connective tissue nevi.
Thank you, Dr. Karai. That was a very, very kind introduction. I'm very glad to be able to talk to everyone. I'm actually someone who listens to these talks all the time, and whenever I miss it, I go to the links and follow them through because I'm very, it's one of the best resources to learn about difficult topics. The talk today is about connective tissue nevi, and my interest in this is not very new, but the approach when I first got interested in this, I would say, was as a resident, because before that we don't really hear about the uncommon presentations or syndromes such as Proteus syndrome or even rarer things like Buschke-Allendorf, etc. But as residents of dermatology or in medicine, we hear about these syndromes and their different presentations, different systems that are involved, and skin being one of them is how I first heard about it. However, now being in dermatopathology, when we see cases and biopsies, we probably are the first ones to find these lesions, and that holds a lot of value because we can go back and help in diagnosing these conditions in many patients. So CPC, the clinical pathological correlation, is very important in these cases, and the fact that we actually can help the patients is the most important valuable piece of connective tissue nevi. So with that, I would start with the definition. Connective tissue nevi are actually hematomas of the dermis, and they result from an increase in or a change of structure of the components of extracellular matrix of the dermis. The three main components that we expect to see in these nevi are collagen, elastin, and proteoglycans, and they can be the main single constituents or they can occur in combination with each other. So collagen, as many of us may know, that it's a 70% of dry weight of the dermis, and mainly its function is to provide tensile strength. Also, it provides attachment site for epidermal cells, and it interacts with proteoglycans, the other components, and other proteins that help in the functioning of the cutaneous connective tissue. So far, we know about 28 collagen proteins, and this is a table that we all come across when we read Bologna. It's a very comprehensive, beautiful table, but the main objective of presenting it here is that you may see that collagen 1, which is the most abundant one in skin. Besides that, there's several collagen that are present in skin, like 3, 5, 7, 8, 14, several of them are present in the skin. And they all have different significance, and as you can see that the main function can be determined by what type of collagen they are, whether they're fibril forming, they're facets, they are basement membrane collagens, microfibrillar, network forming, etc. Based on what their function is, they affect the disease process. So the way the collagen is formed, again, this is a very familiar picture, I'm sure, to everyone. There is a precursor alpha chain, and the three of those would combine and form a procollagen, which when acted upon by a procollagen peptidase enzyme, kind of refines it and gives a collagen molecule. These assemble together in parallel arrays and kind of alternate parallel arrays and form a collagen fibril, and further assemble together and form a fiber. Then the second component was elastin. So elastin and other elastic fibers, they constitute about 2 to 4% of the dermis, and mainly the reticular dermis. Elastic fibers, they're composed of elastin, which forms the center of the structure, and they're surrounded by these microfibrillar proteins, which branch out from there and help to provide elasticity, something like this, where when it is in a relaxed form, it forms this crunched up elastin, but they actually have these cross links amongst between the fibers, which allow for a stretchability, but still keeps it together so it can retract to its original shape, therefore being elastic. Third component being proteoglycans, which are extracellular ground substance, they also help to interact with collagen and elastin. They are made out of this material called glycosaminoglycan, which we all know about, and usually the components there are dermatan sulfate or hyaluronic acid. These are associated with protein cores, and I'll show you a picture of that. And they form a much smaller percentage of the dry weight of skin, about 0.1 to 0.3%. Their function is to help with balance of water and salt, to regulate the metabolism of the connective tissue, and to provide structural support to other dermal components. So this is a basic structure of proteoglycan, where there's a glycosaminoglycan, which has an N-acetylated sugar component, has a uronic acid. This is linked to a linkage sugar, like here galactose xylose, and mainly has a core protein to which these are connected to. So going back to our connective tissue nevi, they can be classified mainly into congenital and acquired, and also further whether they are an independent entity or if they're associated with a systemic disease, which is very important to understand. So when the clinical presentations are seen, they can vary, and the genetic, clinical, and histopathological features, they should all be taken into account when we are trying to appropriately diagnose what type of connective tissue nevi these are. Now, before we go into the details and the classification, I'll touch upon the special stains because they really help us to determine which component we are dealing with. So, as we know, Masson's trichrome stain, commonly used stains, all of these are very commonly used stains actually. It is composed of 3 dyes, and it selectively helps to stain collagen, which is blue or green when it is stained, elastic fibers, which is black, and keratin, muscle, and nerves, and erythrocytes also. All these 4 are stained as red by the stain. Second is the Verhoeven-Van Giesen stain, in short VVG. It stains elastic fibers black, and it does this by forming cationic, anionic, and non-anionic bonds with the elastin, and it also stains nuclei of cells black. Then Alzian blue, it stains acid mucopolysaccharides, and it works at 2 different pH, 2.5 and 0.5. The label and blue at sulfomucin and resistant salomucin stains blue at pH of 0.5. At both the pHs, the sulfated mucopolysaccharides like chondroitin sulfate and heparin sulfate will stain blue. And the non-sulfated mucopolysaccharides will stain only at the pH of 2.5. So basically saying that it stains different types of mucopolysaccharides, and in order to determine which type and what we are dealing with, the pH is important to know. Colloidal iron is the other stain, which stains, again, dermal mucin, very helpful stain that way. It helps to stain salomucin, sulfomucin, hyaluronic acid, and proteoglycans, all of which stain blue. That brings us to the classification. So the main components we mentioned, collagen, elastin, proteoglycans, a mixed pattern with both collagen and elastin, and a fibroblast pattern. Now, this is something that is controversial. Some people don't agree to have it within this classification, but they basically refer to a cellular connective tissue nevi. The component for that, and we'll talk about this later. So under the collagen, elastin, and proteoglycan, they can all be divided based on whether they're inherited or acquired, and several syndromes fall under each of these categories. The interesting thing to note in this table, as we will talk about each of these conditions separately, elastoma-Buschke-Ollendorff syndrome. And all other conditions are can sort of be placed under either collagen components or elastin. Now, the collagen-related connective tissue nevi, as I said, could be inherited or acquired. Under inherited, we have familial cutaneous collagenomas, SHAGREEN patch of tuberous sclerosis, cerebriform collagenoma Proteus syndrome, or the multiple endocrine neoplasia type. Acquired, we have isolated non-familial collagenoma and eruptive collagenoma. Now, when we say collagenoma, actually most of the collagenomas on the skin can look anything between these, I would say, would vary between these three clinical presentations. They can be single, but they can also be multiple, just skin-colored, firm, non-tender, can be nodules or plaques, depending on how big they are. They have a tendency to coalesce if they're multiple. Depending on the syndrome, the other findings help us to determine what we are dealing with. But overall, a collagenoma can clinically be summarized something in between these three pictures. In a familial cutaneous collagenoma syndrome, which is an autosomal dominant syndrome, there are numerous symmetrically distributed, firm, round skin-colored, or even hypopigmented nodules present on the trunk, neck, or arms. They can be small, few millimeters, to several centimeters in diameter, but they're mostly asymptomatic. So patients may not even notice this for a while as they're growing. Some hormonal influence has been implicated, but it's not for certain. And systemic abnormalities when seen can be cardiac, such as cardiomyopathy associated with congestive heart failure, which is attributed to the fact that there can be fibrotic changes in these patients related to bundle of His. And several other less common associated conditions have been seen, like hypogonadism, cafe au lait macules, hypertrichosis, learning disabilities, nystagmus, congenital exophthalmos, and acanthosis nigricans. Now, histology. The epidermis is usually very unremarkable. Sometimes there can be some papillomatosis or even atrophy, depending on how much collagen is pushing against it, but it can be just very normal looking. And with the dermis can reveal within it an increased and irregular arrangement of collagen fibers arranged in a very haphazard manner, along with a decrease in the number and density of elastic fibers. And sometimes it is big enough to go down to the subcutis. Now, there is a dilution phenomena that people talk about. It is sort of like a pseudo phenomena because the elastic fibers are usually not really decreased, but the fact that they are so wide apart because of the presence of thickened collagen, they look like they are decreased or diluted in the dermis. So this is a typical picture of a histological picture of collagenoma, and you can appreciate that the collagen fibers are really thickened and very haphazard. They're arranged in like any fashion whatsoever, and it's giving rise to this nodular structure, which on the patient you would imagine to be a nodule. There's like a hair follicle pushed down here, and we cannot appreciate elastin right here, but it's very helpful to do a VVG stain, therefore, where you can now see, this is a low power image, so but to see the overall picture, it's really helpful that these black thin fibers are here, and they're not very close to each other. There's like wide spaces between them, basically reiterating what I just said about the dilution phenomena. So this is a typical histological picture of a collagenoma. Now, differential diagnosis for a familial collagenoma, cutaneous collagenoma syndrome. So since these nodules can be observed also in tuberous sclerosis or Buschke-Ollendorff syndrome, the way to differentiate is to look for other symptoms of these two conditions, such as osteopoikilosis in Buschke-Ollendorff and adenoma sebaceum, which is a misnomer, we should probably say angiofibromas, of tuberous sclerosis. And they help to get to the diagnosis. The familial collagenoma, cutaneous collagenoma syndromes can also be distinguished from eruptive collagenoma, because when we will be biopsying one lesion under histology, they both may be hard to distinguish, or impossible rather. But if the size is really large and the location is like the neck, trunk, and they're single lesions, then we are likely dealing with familial cutaneous collagenoma, and eruptive ones are smaller and many and have a quick appearance on the patient, and no familial inheritance will be seen in that case. The other condition is white fibrous papulosis of the neck, which, as the name suggests, occurs on the neck, and they don't tend to coalesce like other collagenomas. The SHAGREEN patch of tuberous sclerosis. So tuberous sclerosis itself is another autosomal dominant inherited disorder, but we have seen de novo mutations. It presents with a complex array of many developmental abnormalities and has multiple hematomas that can occur. And there's several cutaneous lesions which are characteristic of tuberous sclerosis, like periungual fibroma, adenoma sebaceum, SHAGREEN's patch. SHAGREEN patch is what is of interest to us in this particular presentation, which is a thickened plaque on the patient, usually on the lumbosacral region, but can also be on the thighs or the trunk. And the frequency of these patches increases as the patient ages. There was a study where they showed that 48% of the tuberous sclerosis patients, they presented with a Chagreen's patch, and this was only secondary to facial angiofibromas, which are more common, which occurred in 75% of the patients. So it's a very good indicator of searching for tuberous sclerosis in the patient. They say that some of the Chagreen patches, they show a decrease or absence of tuberin, which is the gene mutation we look for, and it is an indicator of mTOR pathway alteration, which is leading to actually this aberrant growth. This is more like board-oriented because a lot of residents are probably listening to this right now, and it helps us to remember the different findings of tuberous sclerosis as ash leaf. So A is ash leaf spots, S is Chagreen patches, H is heart, where we get the rhabdomyosarcomas. L is for lung hematomas. E is epilepsy from cortical tubers. I mean, this is the main finding here. A is angiomyolipoma in the kidneys, and F is facial angiofibromas. And some pictures, this is how our Chagreen patch is supposed to look. Most of these connective tissue nevi may be hard to actually look in pictures, but on the patient they seem better because the lighting is different and you can appreciate it better when you're able to feel the rugosity on the skin. Angiofibromas can be appreciated around this person's chin, some also around the cheeks. This is an ash leaf spot, and periungual fibromas. These are all different presentations of tuberous sclerosis, but we are focusing on the Chagreen's patch right now. Now, this can be differentiated from other collagenomas because of the presentation of the other diseases or the presentation of tuberous sclerosis itself, which needs 2 major or 1 major plus 2 minor clinical features. So the major features for tuberous sclerosis are the presence of Chagreen patch, so that makes it even more important to know about, cortical tubers, retinal hematomas, facial angiofibromas, and renal angiomyolipomas. The minor features are bone cysts, hematomatous rectal polyps, confetti skin lesions, and multiple renal cysts. There can be several cognitive and behavioral disorders like autism, other diseases in its spectrum, and a very large percentage of patients can have ADHD. Histology of Chagreen's patch is, since it is a collagenoma, the findings are pretty similar to that of a collagenoma. I would not even repeat it because that's how you see it on histology. And again, the epidermis and adnexa may remain unremarkable. So this is a picture that shows that the dermis here diffusely, it just has acellular collagen and extends very deep, almost to the subcutaneous fat. And if you did a VVG stain, as was done here, almost like there is no elastin in this particular field. So moving on, the other syndrome associated with collagenomas are Proteus syndrome. The collagenomas seen here are known as cerebriform collagenomas. So Proteus syndrome itself is a rare genetic disorder and leads to overgrowth of tissue, including adipose tissue, bone, central nervous system, and skin. The disease has a very variable presentation because it affects so many different tissues, and they attribute it to possibly a somatic mosaicism. Many signs may appear after just a month after birth, but the dermal overgrowths take time. They occur after like about 2 years after birth. There's upregulation of cellular proliferation, which is due to the AKT1 oncogene mutation, and that is part of the PI3K AKT mTOR pathway. That is something that is relevant again for boards for us to know and in general to understand what is the cause of this disease. This picture here shows how the cerebriform collagenomas present. They almost make the entire acral surface mutilated. As you can see, they're really big, and there are several other abnormalities going on. These are not the only things, but these definitely cause a lot of deformity. This is another picture close up to see how we cannot even appreciate the extremity properly. This is the foot of a person. But they can occur on the face, palms, trunk, and arms, but most common areas are the soles. There are several reports where they're isolated plantar cerebriform collagenoma, meaning they're not associated with Proteus syndrome. But we have seen that Proteus, when we see a plantar cerebriform collagenoma, it is very pathognomonic for Proteus. In fact, it's the only category A criterion to diagnose it. So it should definitely raise suspicion to look for other things. They have also suggested that when somebody presents with an isolated plantar collagenoma, a cerebriform collagenoma, it still may be some form of Proteus that the patient may have, just that there is a delayed somatic mutation during the development of the fetus, and that's why they're only presenting with an isolated form. But this is not proven. This is more of a hypothesis. Histology of these collagenomas, again, very similar to other collagenomas with haphazardly arranged collagen fibers. They say there's also that the mucopolysaccharide and fibroblast counts, they are not affected, and elastic fibers may actually be diminished. The differential for when we see a patient with this condition is Maffucci syndrome, Klippel-Trenaunay syndrome, neurofibromatosis, and Banyan-Riley-Rubalcaba, but these do not have collagenomas. They just give the appearance of distortion of the similar surfaces on the body, but due to vascular malformations or because of neurofibromas or lipomas, respectively. The plantar cerebriform collagenoma, it is not present in any of these disorders, so that's not what it's associated with. So it's not very hard to distinguish. The last one in this group is multiple endocrine neoplasia type 1. It's a rare autosomal dominant hereditary syndrome which predisposes to tumor development in several endocrine organs. It has both familial and sporadic forms, several manifestations, which is something that we have read several times probably in the past, like hyperparathyroidism, pancreatic and pituitary tumors, and other endocrine and non-endocrine tumors, both benign and malignant. Again, the diagnosis has a criteria. It requires 2 of the 3 major manifestations. The main dermatologic manifestations in men 1 are angiofibromas, lipomas, cafe-au lait spots, and collagenomas. And again, I would flag this as important for the board exams for those who are preparing for it. Regular surveillance and targeted therapy is required for the men 1 related tumors, and really a lot of monitoring is required in these patients to look out for all the different types of tumors that can occur. This picture is a good representation of what mucosal neuromas can look like in men 1, like involving the tongue, but they can also be on other surfaces inside the mouth. The histology of like I mentioned, the collagenomas, again, very similar to all other collagenomas. But there was a case study by Zia et al. That reported that several collagenomas in a men 1 patient that were protuberant, and they were kind of more nodular and polypoid in nature than was seen before. So differential diagnosis for men 1, we should think of men 1 when there are eruptive collagenomas, which are actually in a different category. They can be in a non-inherited category. So either way, when there are eruptive collagenomas in a patient, and there are also associated facial angiofibromas, then we should check for the patient's history of endocrine tumors and consider men 1. But again, if you also see facial angiofibromas, you have to think of tuberous sclerosis as well. Moving on to the acquired collagenomas, connective tissue nevi, the isolated non-familial collagenoma, as the name suggests, there is a localized increase in type 1 collagen production, and there's a decrease, mainly because there's a decrease in the amount of the enzyme that should break it down, the collagenase enzyme. These may present again in any form. They can be hypo or hyperpigmented papules, nodules, plaques. There can be different patterns. They can be arranged in a linear, grouped, isolated, irregular, but they are usually asymptomatic. And there's a single plaque on a trunk, back, or arm. That is the most common presentation. So just one collagenoma. It's not associated with any syndrome, so that is an easy go for the patient. The morphological patterns are so diverse, like there's a zoster-form presentation, which has a segmental distribution dermatomal, like the name suggests. A corymbose, which is very interesting to me, so I put a picture here of what a corymbose pattern means, like these flowers, or certain plants, they exhibit that pattern. It's like there's a large central plaque, and then there are other smaller ones around it. Cerebriform, as we know, representing something like brain sulci and gyri, like we saw, and papillolinear, where there are linear, and then there are several other ones around it. They resemble like scars. Histology, same thing. Increased but irregularly distributed collagen and decrease in some elastic tissue or dilution phenomena, which is typical. But the scar tissue that has a thin epidermis and has fewer adnexal structures, that can be tricky. So we should think of a scar tissue. So sometimes VVG really helps in checking whether we are dealing with scar or collagenoma. The differential diagnosis, as we first went through them, the familial cutaneous collagenomas that we already talked about, but there's a lack of familial history in these patients, and the eruptive collagenomas because of the appearance and distribution. The second type of acquired collagenomas are eruptive. They are much smaller, actually, and they resemble nodules that are seen in familial collagenomas, but they occur in the first decade of life, and but they are also seen in adulthood sometimes, but more common in the first decade. They are raised fern, skin-colored, usually hypopigmented and tiny, so they may not be more than a centimeter in size. Their appearance is sudden and persist. Extremities and trunk can be involved, and this is a picture from a paper that had a very good description. And I mean, there can be a differential for this presentation, make you think of xanthomas. So a biopsy will help to figure out what exactly the histology shows. So as we know, the histology should show here normal epidermis, a decreased fragmented elastic fibers, and accumulation of collagen fibers in the dermis. Fragmented elastic fibers cannot be seen in all types of collagenomas, and if we do see them, we should also think of some other conditions that have elastic fibers that can be fragmented. But I don't think we have time to go over all the differentials on that right now. Such as things like we have to think about whether we are dealing with dermal elastosis syndromes, or we are dealing with PXC if the elastic fibers are bundled up and they deposit some calcium on them. So depending on what we have, what the elastic fibers look like, we have to take it with a grain of salt is the bottom line. However, the collagen bundles that have been found to be irregular and variably oriented, very similar to other collagenomas, they are present perpendicular to the epidermal surface. And then they can be very coarse looking, but at the same time, they can be very thinned out as well. So again, this is a picture where we can see a lot of collagen fiber accumulation, but they're haphazard, and they're in different orientation. So here we are seeing more like tiny in this cross section, but here you can see the longer fascicles going through. And again, when you do the VVG stain, you can appreciate that these are fragmented elastin fibers. The black structures is a small mark here, arrow to point to it. The differential diagnosis on this is white fibrous papulosis. Again, it's present on the neck as we discussed, and this condition is actually more common in European females. The eruptive colagenomas are more prevalent in Caucasian males, but when they're present in Japanese population, it doesn't have a gender bias. This is something may be important for the boards to remember. Going to the second component, elastin. So there are inherited elastin connective tissue nevi, such as those seen in Buschke-Ollendorff. So as I mentioned earlier, Buschke-Ollendorff can have collagenomas and elastomas. So this disease is autosomal dominant, again, and it has small asymmetrically distributed papules in extremities and lower trunk. The papules here, we have to be careful because we could have, the biopsy will help because if we are dealing with elastomas versus collagenomas, not that it is going to impact the management per se a lot, but in order to proceed with which syndrome are we dealing with, it can be helpful. These are present on buttocks, back, thighs, and scalp, and they have a yellowish to skin colored to them, and they are called as dermatofibrosis lenticularis disseminata. Again, something board important. The onset of these papules before puberty can occur, they may be congenital, and the number increases with age, like we also saw for certain types of collagenomas, like the SHAGREEN patch. The collagenomas and the mixed connective tissue nevi are associated with it, as I mentioned, and there can be an incomplete form of Buschke-Ollendorff, where only elastic connective tissue nevi may be present, and these are also known as familial elastomas. So as I mentioned earlier, all these connective tissue nevi, they're kind of hard to appreciate on pictures. And this is actually still something that one can appreciate, that there's a ill-defined plaque of skin-colored or flesh-colored in nature, and it has rugosities on it, irregular surface. But it may not be very easy to appreciate. It's better to see it on the person and feel it. And the classic thing about Buschke-Ollendorff, very important to know, is osteopoikilosis, which is a bony change, and this word by itself is a Greek word which means spotted bones, and it's a skeletal abnormality which is characterized by small round areas of increased bone density, which appears as brighter spots on x-rays, as can be seen here. And again, the most common areas to be seen is ends of long bones of arms and legs, but can also be seen on hands, feet, and pelvis. These areas of increased bone density, they appear during childhood, and they do not cause any health issues. So they are not really prone to increased fractures. They just have spotty bones. Now, cases of familial juvenile elastomas, they have also been reported, but they need a follow-up in order to see if they really develop osteopoikilosis or if they really have the full diagnosis of Buschke-Ollendorff. They may just be limited to having elastomas. The sclerotic bone lesions, like I said, they are not symptomatic or really clinically relevant to the presence of elastomas, but the fact that these bony changes are seen, it is thought that it is a result of ectopic elastin in the bone. That's why we get these spots. Sometimes these patients of Buschke-Ollendorff can also have peptic ulcer disease and cataracts, which may have something to do with the elastin as well. The other condition is known as juvenile elastoma. Again, like I said, it only gets worse, and it's very hard to appreciate that there is a rugosity on the skin here. There's an irregularity in this child. I tried to find better pictures on this, and there's, again, like a ill-defined plaque, not the best ones, but there are not that many great pictures on this. I'm sorry about that. Okay, and that's why where the Verhoev von Wiesenstein really helps is to highlight the collections of these thickened elastic fibers. So here we are focusing on the elastic fibers, which are not really diluted. In fact, they are thickened. They are much more visible. They form these bundles, and that's what makes it consistent with an elastoma. This is another histology from a Buschke-Ollendorff patient where we can see that the collagen fibers are really thickened overall. And we have to do a VVG to really appreciate the elastin, which I don't have a picture of here, but you can appreciate that the dermis is really thickened with dense collagen. So here we are dealing with a collagenoma, in contrast to an elastoma here that we saw where the elastin was being highlighted. So these patients can have both, which is a helpful finding. The epidermis here, like I said, is normal or even can be atrophic, and elastic fiber accumulation is seen. Usually don't have fragmentation. They're actually instead broadened, branched, thickened, and interlacing. The collagen around them may be present. They may be encompassed by these thickened elastic fibers. And there's an increase in desmosine, which is one of the components of elastin, by 4-fold to 8-fold, due to which we see this thickening, especially in the papules of the DLD lesions. There are additional features like granular deposits and central defects within the elastic fibers, as well as granulation and enlarged the RER, the rough endoplasmic reticulum within fibroblasts. So, of course, this is not something we can appreciate on histology. We'll probably require electron microscopy for this. Once again, you can appreciate that here they're so thickened that even on histology we can appreciate that there are elastic fibers present, and we can highlight them. They're really broad, ribbon-like almost, and they are running parallel to these collagen bundles. In the acquired elastic connective tissue nevi, again, as the name suggests, this is not something inherited or the patient's born with or associated with syndromes, but something that we commonly read about, elastosis perforans serpiginosa, very high yield for boards. These are 1 to 5 millimeter hyperkeratotic papules. They present in circular or arcuate, arc-like configurations, commonly on the neck or face, but can be anywhere on the body. They may be acquired or have a perforating form of inherited PXE, so the pseudoxanthoma elasticum, although the mode of inheritance is not really known for these. There are several associated disorders, and again, I would say these are high yield for our board exams, like osteogenesis imperfecta, Marfan syndrome, Down syndrome, Ehlers-Danlos syndrome, and in some patients who take D-penicillamine. So this is the typical, this is one of our patients who had a very nice arcuate elastosis perforans serpiginosa lesion on her neck. And these are the other ones that you can see here, beautiful lesions. And whenever you see this, it's pretty much like a spot diagnosis. But when you do histology, we can appreciate that there's an increased density and size of the elastic fibers in the dermis, highlighted better by VVG stains, and a transepidermal elimination of the elastin fibers can be seen. These are very nice, they make your day kind of histology. And this appearance is known as the bramble bush appearance, which is associated with D-penicillamine use more commonly. So, like I said, the D-penicillamine-associated elastosis perforans serpiginosa has the lateral protrusions from the elastic fiber bundles, and that is called the bramble bush. This is a bramble bush, more like a pictorial diagram. This is a real bramble bush, and this is what the penicillamine-associated EPS bramble bush looks like on histology. There's also necrotic elastic fibers that are ejected through an umbilication that forms in the center, and then a channel that opens outside, which is known as the transepidermal elimination. And sometimes these can get calcified, and which is unusual to happen in EPS. But in PXE, it is much more common to see dystrophic calcification of these fibers, and that helps us to distinguish between the two also. There can be granulomatous inflammation around these thickened and collected elastic fibers in the dermis as well. Now, what are the differential diagnoses for EPS? Perforating folliculitis, of course, because it also has a very similar transepidermal elimination thing happening. And if there's expulsion of, in that case, though, there's expulsion of modified connective tissue elements through the epidermis and not elastin. The other lesion to talk about is isolated elastoma, and we are becoming more and more localized now. We are going away from syndromes. So nevus elasticus is also what it is known as, and in this case, it is an elastin connective tissue nevi in the absence of family history. So maybe like one single lesion. Some patients have developed multiple papules also, and then later on they have found that this patient had Busch-Ollendorff. So we have to be on a lookout. We cannot know right away. Again, there will be a mostly normal-looking epidermis, but there may be an increase in the dermal elastic fibers, and VVG is a good stain to confirm this, as we talked about. So nothing different from a normal elastoma, but the clinical history and presentation are helpful. The differential diagnosis on this, we have to rule out our Busch-Ollendorff, so osteopoikilosis by an X-ray, family history, and in addition, if there are papules that are clinically, they look like elastomas, but they actually lack elastin fibers, there's a name for that as well. It's called nevus anelasticus. The third component is proteoglycans. So inherited proteoglycan connective tissue nevi are seen in Hunter syndrome, where there are dermal nodules, which are composed of, which belong to the category of mucopolysaccharidosis 2. This is a recessive X-linked genetic disorder, and it is characterized by this enzymatic deficiency and of alpha iduronidase. Self-iduronidase, I can never say this word, and is a buildup of mucopolysaccharides. This is what we are expecting in those connective tissue nevi here. So there can be a general thickening of the skin in these patients, but in Hunter syndrome, the one standout finding is that around the scapula, there are these ivory white papules, something that we have to always remember for the boards again. And the pebbling of the skin, there can be multiple lesions, they can be symmetrical, they can be very small, 1 millimeter, they can be up to a centimeter, but this is a very typical thing that they like to know that in the exams. There were 4 cases reported by Prostowski, and they showed that 2 of those patients had identical histological findings in the proteoglycan connective tissue nevi. They showed irregularly organized collagen bundles, and they were separated by something that was present in between, like an interfibrillar material. And when they stained it with toluidine blue, they found it was metachromatic. Upon light and electron microscopy, they finally discovered that it was some kind of glycosaminoglycans that are present. So that's what forms these type of connective tissue nevi. Now, particularly Hunter syndrome, it is very difficult to distinguish it from other types of mucopolysaccharidosis, and we have to do an enzyme assay to find out which one is the patient have. The acquired ones of connective tissue nevi with proteoglycan deposits would be lichen myxedematosus, something that we much more commonly see in comparison to everything else we talked about so far. These have multiple densely arranged papules, seen more commonly in actually middle-aged adults, and mostly affecting exterior forearms and in the axilla. They do not have endocrine irregularities. There are 5 subtypes that have been described: nodular lichen myxedematosus, papular mucinosis of infancy, self-healing papular mucinosis, acral persistent papular mucinosis, and the discrete form of lichen myxedematosus. In histology, the epidermis is normally doesn't have much changes, but it can be atrophic or papillomatosis depending on if it is pushing against the epidermis, how much is accumulated. And then a very typical finding is that the upper third of the dermis demonstrates this parting of collagen fibers because in between them are deposited the glycosaminoglycans, mainly hyaluronic acid. And they might be a result of synthesis because there is an increased number of stellate, large, elongated fibroblasts. Or it can be thought of that the fibroblasts are more stellate and elongated because they are doing more work by producing more of the mucopolysaccharides. There can be the other findings of sclerosis and deposition of collagen are not seen, which is very helpful. The negative findings are important because they help us to rule out some of the other conditions. And of course, whenever we deal with lichen myxedematosus, scleromyxedema comes to mind. And it is important to remember that the difference between this type of local lichen myxedematosus and scleromyxedema is that systemic findings are not seen in this case, while scleromyxedema can have thyroid disorders, can have monoclonal gammopathies associated with it. And the presence of this dermal mucin can be confirmed by using any of those stains we talked about earlier, like alkaline blue or colloidal iron. So this is a good histological picture, very characteristic. You can see how the collagen fibers are parted, and it's pretty obvious that there's something deposited in between. This should always prompt us to stain it to confirm. Although, looking very closely, also you can appreciate the mucin, which forms kind of granular bluish material deposited. But just to be more sure about it, we can stain it. And this is another diagram where we can see that, you know, this was a low power image here. Separation between the collagen fibers can be seen. There's something in there. And when you stain it, it beautifully stains for all the mucin that is present. And this is just showing us more higher power, how the separation is. This is very cellular because there are so many fibroblasts present very close to each other, but still leaving enough space for the material that they're actually producing, the mucin. So as I mentioned earlier, scleromyxedema is a differential diagnosis. I've already talked about that. And other kind of deposition diseases in the skin would come to mind when we see it clinically, like amyloidosis, which you can stain for by doing any of the stains that, you know, lab has its own liking for a certain stain. Like in where I am training right now, we like to do thioflavin T and look under the immunofluorescence microscope. But Congo red, pagoda red, Giemsa, different stains can be used to distinguish. Another one that has mucin deposition is known as focal cutaneous mucinosis, where there's excessive production of hyaluronic acid due to an increase in the amount of fibroblasts. So it sounds very similar to like in myxedematosus, and the location is papules. We get basically papules, nodules, sometimes plaques on the trunk and face and extremities. So location is slightly different, and it stays far away from the joints. They came up with a new variant in a paper from Ozio et al., and they said that this should be called follicular mucinous nevus, but it is mainly that it's a broad plaque, and there's some dilatation of hair follicles because of the fibromucinous stroma in the dermis and involving more the perifollicular region. So there's an increase in fibroblasts which is seen, and that's why we are having, so anytime we are having increase in fibroblasts, it is an indicator that, you know, they are going to produce more hyaluronic acid, eventually pushing away all the collagen fibers, making space for themselves, sometimes so much so that there will be fragments of few collagen fibers remaining. It is much more dramatic than the lichen myxedematosus. And a basophilic mucinous deposit can be noticed. There can be edematous-looking changes, and sometimes there may be an associated lymphocytic perifollicular and perivascular infiltrate that we may see. One of the interests, since it is a focal lesion, it's like one papule, tiny papule, or one localized area, we can identify it with the help of these collarettes on histology. Otherwise, we can appreciate here there's an atrophic epidermis because of the collection of mucin in the superficial dermis, and like I mentioned, the collagen fibers are like wisps. They have been shredded and they are all taken over by the mucin. Differential diagnosis for focal cutaneous mucinosis are myxoid cysts, which are also accumulation of mucopolysaccharides, but they can affect only, they generally localize themselves to like digits, where we often they may have a connection with the joint space. And okay, before I move on, and in order to treat the myxoid cysts, we have to use caution that we have to make sure that the joint space is also obliterated, otherwise they're going to keep coming back. I think this is the last type of connective tissue nevi I'm going to touch upon, a mixed pattern. It's not very complicated to understand. It has both collagen and elastin, but not much is known about why they occur together, or what is the presentation, why both these components increase and form a nevus like that. Sonal et al., they showed that most of the connective tissue nevi studied under this category, or rather any category, they are mixed in nature to a great extent. The pure connective tissue nevi, just elastoma or just collagenoma, are actually very, very rare. And if we look harder and do many more sections, they're probably, most of the connective tissue nevi are mixed, which makes a lot of sense. So there should be a more continuous spectrum of some connective tissue nevi having more of one component versus another, but overall they're probably all mixed. And the cellular one, which is the controversial one. So like traditionally we have collagen, elastin, proteoglycans, but recently they have studied that fibroblastic or cellular connective tissue nevi can be seen where there's an increase in the amount of fibroblasts in the dermis. It can go down all the way to subcutaneous tissue or both, and we can appreciate that on histology. The collagen may also be increased, but elastic fibers may be increased, decreased, or just not be affected. So there's a differential diagnosis for a cellular connective tissue nevi because there's increased fibroblasts, juvenile fibromatosis, where we see long fascicles of fibroblasts and myofibroblasts has to be considered. These are positive for CD34, so that would help us to differentiate it from cellular CTNs. The other differential diagnosis, so anytime we are going to see something so cellular and fibroblastic, a lot of things will come to mind, like dermatofibroma, DFSPs, plexiform fibrohistiocytic tumor, and it will prompt a larger workup. It may not be very easy to just look at histology and be 100% sure that that's a connective tissue nevus. So a lot of stains and a panel of stains may be required to rule out one from another, unless there are some very obvious significant findings to demonstrate one of these lesions. Now, the juvenile fibromatosis, they are present in they can present in very young children or in infants. However, these are more common in adults, but there's some reports of presence in childhood, but mostly in adults, and they're found on the trunk, head, neck, and limbs, and they're smooth, firm, poorly circumscribed, tan, thickened plaques, painless nodules. Size varies, as we mentioned earlier, and there's not much known about these type of connective tissue nevi besides this information. So recently, we did a literature search, and there was a paper that got accepted on this topic. And we really looked at everything that's in the literature about connective tissue nevi, especially from the point of view of treatment. And I'll cut that short and just focus to the point. But the interesting finding was that any of these, whether they're collagenomas or DLDs or Buschke-Ollendorff or lichen myxedematosus, even mucinosis nevi, all of these varied in presentation. So even if somebody presented with this very young in their life, actually when they reached for medical attention was really variable. So even if they got it when they're 2 years of age, that was not bothersome enough or not scary enough, or was not growing fast, or whatever was the reason, they were so asymptomatic that they did not seek medical attention for a really long time, which is very interesting. And it is also important to know this fact because it helps us to actually diagnose syndromes based on these findings. So if we catch them very, very late, we may miss out on some of the other things that we could have helped the patients with. Also, collagenomas, as we may expect, were the most common type of connective tissue nevi, second common being mucinous nevi in our review of literature. The management, and I won't read all of this, but the PowerPoint may be available later to go over, that a lot of things have been tried. And the bottom line is that nothing seems to work every single time. It's very individualized treatment. So people have tried in their studies with cryotherapy, which has not worked most of the time. The one thing that has worked is intralesional So for collagenomas, they use intralesional triamcinolone, and in many cases it worked with repeated use, decrease the size of it, may not 100% go away. They have found cases that were associated with pregnancy, and that's what I was referring to when I mentioned some kind of hormonal association. And actually the one patient that was reported with pregnancy developing collagenoma, the collagenoma went away, decreased in size, and resolved after the delivery of the baby. Management of familial collagenoma actually has no reports on management. So either people have not reported it or has not been very successful enough to report. But different types of procedures like excision, dermabrasion, even applying moisturizing lotion has been reported. And a lot of things that don't hypothetically make a lot of sense. And again, DLD is another thing that of Buschke-Ollendorff that has no reported management. This was interesting because there was one report where they actually showed after 1 year of follow-up with intralesional corticosteroid injections into these collagenomas. This was in a Coram-Bowes fashion, the papular nodules. They injected IL triamcinolone intralesionally, and then this is the outcome after 1 year. So it's not the most cosmetically acceptable outcome, I would say, but it is definitely better than this. However, they're asymptomatic, so we have to think about that before we use any of these methods. For lichen myxedematosus, they also had different types of treatments used. Intralesional triamcinolone, of course, being one of the most successful ones because it did not lead to recurrence in their patients. But they have also tried pimecrolimus. They have irradiated one of the lesions and several other types of topical treatments. Mucinous nevi have been treated with either surgery by excision, dermabrasion, CO2 lasers, or have simply been monitored, but in several cases, some of them even resolved without even receiving any treatment. So that is very interesting because maybe the mucinous component just dies out over a period and the fibroblasts just don't produce any more mucin and the rest just gets absorbed. But like I mentioned earlier, before seeking any medical attention, these lesions were present in patients from birth up to 50 years. So the important thing to understand here is that we may need multidisciplinary care if we find a syndrome. For those that are not associated with a syndrome, we can just monitor them or may not need any further evaluation. But if we do find, then like for patients with tuberous sclerosis, Proteus syndrome, Hunter syndrome, there is a very high risk of multiple organ involvement, and therefore they need a full medical evaluation. Orthopedic consultation may be needed for Buschke-Ollendorff just to make sure that we are dealing with simply spotty bones and nothing else. Hunter syndrome can have several musculoskeletal involvement, so they may need orthopedic consult. Neurologists should be involved with the care of tuberous sclerosis. As we know, they have CNS involvement with cortical tubers, so definitely. They also need ophthalmological evaluation because they have retinal hematomas. So I'll just conclude this presentation by highlighting the very important things we went over, that connective tissue nevi overall, they're benign tumors of the skin, and they may be isolated growths or they may be one of the components of a syndrome. The classification of these nevi or this tumor, they have been modified several times, and now we have just come to understand that they may be on a spectrum, depending on which component is the maximum seen in a particular lesion. They should, these tumors, they not only should alert the physician towards a detailed history, physical exam, family history, but also they may be of cosmetic concern to the patient. So from that point of view, we have to come up with the best form of treatment, which is actually not studied well so far. And again, the treatment will vary depending on what type of connective tissue nevi, what was the age at presentation, what part of the body is involved, if there is any syndrome involved with it. And if there is a syndromic involvement, complete evaluation is necessary. Monitoring of the lesions, it just may be appropriate. If it is not bothersome, then you can just explain to the patient, reassure them, and leave it alone if it is not interfering with their day-to-day life. Surgical treatments were reported in majority of the cases, and they were actually very successful because these lesions don't tend to recur. But depending on how big the lesions are, this may not be an option. Alternatively, as I showed in one of the cases, intralesional administration of steroids, really that's how the appearance of the lesion will become if we treat it with IL steroids, if that is sort of the size of the lesion you're dealing with. But if they're really tiny, it actually may help because it will flatten it out. So with that, I would just conclude my presentation, and I'm not sure if questions are allowed or how to conclude, but thank you so much for listening.
Dear Sonal, thank you very much. It was a beautiful clinical pathological review of connective tissue nevi, and at the same time, because you are so close to your final exams, it was also a board review. So this talk can be also used very much for board review purposes. Thank you very much.